Welcome to our to Combo this time, even from distance. We're really looking forward to hear your presentation. Thank you.
Thank you. Thank you very much. I will just put the slides on so that we are in the position to start. So good afternoon, everybody. Once more, many thanks to Professor Diamanti and to the organizers of this course for the kind invitation. It's the second time I am participating, this time indeed remotely. But I think that we have proven that nothing can stop us contribute to a course like Combo. And a course in which excellent delegates are taking part. So I've been asked to cover the area of opiate-induced endocrinopathies, an area which I think is expanding, and it shows that the borders of endocrinology do not stop. So let's start with the opioids. What are opioids? Opioids are natural or synthetic substances that bind to the opioid receptors, and these are in the central nervous system or in other tissues. And these receptors are these classical G protein coupled receptors. We have three main classes named after Greek letters: Mi, Kappa, Delta. Obviously more have been discovered, but these are the main ones. And the pharmacodynamic response to an opioid depends on the type and the affinity for the receptor it binds. So overall, it can exert agonist or antagonist action. And a little bit of more pharmacology. The main classes are the natural opiates, which are the alkaloids of the opium poppy, mainly morphine, codeine, and thebaine. Esters of morphine, like heroin. Semi-synthetic opioids, which are produced from the natural opiates or the morphine esters, like hydromorphone, hydrocodone, oxycodone. Fully synthetic opioids, like fentanyl, pethidine, methadone, tramadol, and the endogenous opioid peptides, which obviously are produced in the body, like endorphins, enkephalins, and we will not focus on them in this talk. What are the uses of opioids? Mainly is relief for acute or chronic pain, cancer or non-cancer related, and it is indeed in the human nature to avoid suffering. That's why we want to ameliorate or improve pain. However, they can be used for cough, for diarrhea, for enhancement of anesthesia during surgery, for suppression of the respiratory activity in patients who are ventilated, and for the maintenance or detoxification therapy in opioid dependence, like the methadone. Obviously, there are non-medical uses as well, and here we will focus on the recreational use due to the euphoric effects, like the illicit use of the opioid heroin. And this is a table from the British National Formulary, which shows what exists in the UK and what is the route. So we have various routes of administration and the indications. And in fact, this table confirms the wide uses of opioids, with main, of course, the pain relief. Some statistics now. This is a graph which came from the drug abuse in 2014. These are American data, and they clearly show how the use of the various opioids has increased over the years. So this is oxycodone, this is hydrocodone, and the total is shown in the columns. If we go to 1991, and if we go to 2013, we see a massive increase from 76 million prescriptions going to 207 million prescriptions. So it's a massive increment. And actually, the United States seem to have the lion's share in this market. They account for 69% of the world's supply of opioids, nearly 100% of oxycodone, 50% of morphine, 73% of oxycodone, and 53% of hydromorphone. And the United Kingdom is not behind, really. Of course, it doesn't have the massive numbers of the States, but we can see the increment in the use of strong opioids, both for cancer and non-cancer patients. And these are from the UK Clinical Practice Research Data Link. Other countries, what is happening there? So this is a table which shows the international use of 6 powerful opioids. And we can see that Canada is first, followed by the States. But what hasn't been put in is the hydrocodone, which is widely used in the States and obviously would put the United States first. Despite this, we can see that Canada, Denmark, Germany, Australia, UK indeed have a high use of powerful opioids, suggesting that the problem is universal. And what kind of healthcare professionals prescribe these medications? It's not just the colleagues who deal with pain management. As you can see from this graph, it can be family practice, it can be internal medicine, it can be orthopedic surgery, anesthesiology, general practice, rheumatology, cardiology, nephrology. Practically all the specialists can prescribe these medications, and this means that the group of physicians or healthcare professionals, we have to focus to enhance awareness for the problem and the need for monitoring. So this group is quite wide. And these are some statistics for opioid use disorder. So these numbers in the columns, we have to multiply this by thousands. Again, significant numbers. There is a drop between 15 and 16, but still the numbers are quite substantial. So how about the number of heroin users? So we leave the area of pain relief and we go to heroin, to illicit use. And these are again data from the United States, which show that the use of opioids over the years has increased. And actually between 2005 and 2012, it has nearly doubled. And these are formal data. Obviously, non-formal or non-reported cases should be there and should make the numbers even higher. And the next question is, why do we have this increased use? And it seems that there are many factors that we could think of. Number one, there are changes in medication formulations. So in many countries, people can buy tramadol or other similar medications from as tablets from over the counter, from not just the chemist requiring prescription, but from any shop, even supermarkets that could sell them. Second contributing factor is the marketing of the pharmaceutical industry. We live in a world of business, in a world that sales matter. Another cause is the increasingly aging population. Elderly people, of course, they have higher chance, higher probability of suffering from pain and requesting relief. Another potential reason is the cultural acceptance of drug taking as problem-solving behavior. And of course, we go now into the depths of psychology. And another cause, which I think is very important, is the lack of information. I've spoken with a number of physicians here and who are not endocrinologists, who are not doctors who deal with pain, and they have told me that they had never heard of opioid-induced endocrinopathies. And now let's cover the first axis, the hypothalamo-pituitary-gonadal axis. And this is a statement. This is a statement from Charles Alexander Bruce. He was a soldier and a father of the tea industry in India. And he produced a report on the manufacture of tea and on the extent and produce of tea plantations in Assam. This is an area in Asia. This was done in 1839. and what did Bruce said in 1839? He said that opium has kept and does now keep down the population. The women have fewer children than those of other countries. The feeble opium smokers of Assam are more effeminate than women. So the first clue comes from nearly 200 years ago. And of course, science and endocrinology later, much later, proved that opioids have a suppressive effect on the hypothalamo-pituitary-gonadal system. How is this done? At the hypothalamus, they cause reduced release and disruption of the normal pulsatility of the GnRH. At the pituitary, they have a direct effect on the release of gonadotrophins. And at the level of the gonads, it seems that there are direct effects with decreased production of sperm, with reduced production of testicular interstitial fluid and intratesticular testosterone. And we shouldn't forget that occasionally these medications can cause hyperprolactinemia with a known suppressive effects to the HPG axis. What is the prevalence? The prevalence, if you look at all studies, the prevalence of hypogonadism due to long-term use of opioids is between 21 and 86%. It's a wide range. And I think that this relates to the variable studies in terms of dose, duration, type of opioid. But irrespective of this wide duration, even if we stick on this 21%, certainly this is not a negligible number. And the first studies published on that topic, on humans, they were on heroin addicts. And this was in the 70s. So heroin addicts and patients on methadone for maintenance treatment. And it was clearly shown that by having these medications or substances, there was a reduction in the testosterone, which occurred even within a few hours. And although less well studied, amenorrhea in female heroin addicts has also been reported. How about cancerous and non-cancerous pain? Again, a plethora of studies showing that there is hypogonadism in both male and female patients on oral, transdermal, or intrathecal opioids. So any route of administration can cause a problem. We shouldn't forget, though, that there are probably other contributing factors to the suppression of the HPG axis, like the pain, the comorbidities of the patient's age. And it seems that, again, in these patients, in the cancer and non-cancer patients, the effects start as soon as the opioid is taken, and it also seems that they are dose-related. Just a few pieces of information which I find interesting on this topic. It has been suggested that the chronic use of long-acting opioids is associated with greater odds of androgen deficiency than of short-acting opioids. And interestingly, the buprenorphine, which is a partial Mi receptor agonist, leads to less severe hypogonadism compared to methadone. And there may be a tendency in the years to come to use buprenorphine more often compared with other opioids. There is certainly recovery after stopping this therapy, but the time course has not been systematically studied. Management. Management is discontinuation, if possible, or reduction in the dose of the opioid. Consider alternative therapies for chronic pain. Certainly a number of patients do not need these medications to feel better. And if these are not possible, we have to consider gonadal hormone replacement. And there are very few studies which have looked particularly at this group of patients and see what are the effects of testosterone replacement. So I will show you the data from 3 of them, in which they used gel or transdermal patches for 14 to 48 weeks in males on opiates for chronic pain this time. And the study showed that there was improvement in the sexual dimension of aging male symptom scale and in the mental index of the SF-36 questionnaire. There was improvement in the androgen deficiency symptoms, in the sexual function, in the psychological well-being and depressed mood. And of course, these are more or less expected given the known effects of testosterone replacement on hypogonadism. But another interesting finding is that there was improvement in the mechanical and pressure hyperalgesia. In other words, maybe testosterone replacement would have a positive effect on pain sensitivity. Series looking at gonadal hormone replacement in opioid-induced hypogonadism in women are not available, but I'm sure that a lot of us have had women who required HRT because of suppression of the HPG axis. And needless to say, what are the consequences on the fertility of these patients? So that was about the gonadal axis. Another area which needs attention, and I think it hasn't attracted the attention it should, is the bone health. And again, studies have shown that these patients have reduced bone mineral density and increased fracture risk. Of course, could it be that the increased fracture risk relates more to the increased risk of falls, because we know the adverse effects of these medications? Maybe. Potential causes are not only the opioid-induced hypogonadism, but it seems, based on in vitro data, that there is direct effect of opioids on bone formation. So it has been shown that opioid receptors are on osteoblasts and that opioids inhibit the growth of osteoblasts in culture. So for the HPG axis, the gonadal axis, we certainly need further studies to establish the long-term benefits and risks of hormone replacement in this particular group of patients. And importantly, equally importantly, the impact of hormonal replacement on pain sensitivity and on the recovery of patients on methadone for opioid use disorder. Would these patients, by being on a testosterone replacement, for example, have a better sense of well-being, and then this can facilitate their journey to come out of the opioid abuse? Time will show, and certainly more studies are needed. For us, the clinicians, we have to remember, and probably this is one of the most important take-home messages, is that the opioid-induced hypogonadism does remain underdiagnosed. And maybe the lack of symptom reporting by patients, combined with the underappreciation of this common problem amongst clinicians, are the causes of this underdiagnosis. Therefore, manifestations of hypogonadism should be inquired before and during the opioid treatment, and the patients should be educated on this potential side effect and encouraged to report relevant symptoms if they experience such. And regular hormonal screening is needed for these patients. Now, let's move on to the other fascinating axis, the hypothalamo-pituitary-adrenal system. Again, studies in normal subjects, in healthy volunteers, have shown that single administration of various opioids like morphine, heroin, buprenorphine causes suppression of the ACTH and the glucocorticoid secretion. It causes blunted pituitary adrenal response to the CRH, and it also causes diminished cortisol response to the psychosocial or surgical stress. And other studies on longer-term use have shown that the opioids suppress the axis at hypothalamo-pituitary level, again by inhibiting CRH and vasopressin secretion, and by reducing their effect on ACTH and cortisol release. And there are some clues that there may be also direct effects on the adrenal function. So these are the mechanisms. In clinical practice, there are several case reports which have documented secondary adrenal insufficiency after oral or transdermal opioid use of variable duration And we have to keep in mind that there are reports which mention even a few days of use. And these are mainly for patients who use them for pain relief. Unfortunately, the accurate prevalence of adrenal insufficiency in these patients is not clearly defined. And again, a major confounder is the chronic pain. What is the impact of chronic pain on the HPA axis? What are the adaptations of the body and the hormonal systems on chronic pain? And here are two studies which tried to investigate this issue and see what is happening in real life, in clinical practice. The first one was published relatively recently, comes from the United Kingdom. And the authors looked at 48 patients on long-term opioid analgesia. These are the medications which had been used. And this should have been offered for at least 6 months. And recent exposure to exogenous glucocorticoids had been excluded. And what were the findings? Well, morning cortisol below 100, so we divided nanomoles per liter. For the Greek units, we have to divide it by around 28, was in about 8%. Failure to respond to the synactin test with peak cortisol below 430 nanomoles per liter, and these were the cutoffs of the lab, of that lab, was in about 6%. And importantly, when the authors focused particularly on 3 patients who were on high-dose opioid analgesia, excluding tramadol and dihydrocodeine, around 10% of those assessed had an initial suboptimal cortisol response to the synthetic ACTH. Another study, published many years ago by Roger Abbs in the GCNM, had shown that in patients who had intrathecal, this time, administration of morphine or hydromorphine, and this was a group of 72 subjects with non-malignant pain, and the mean duration of treatment was 27 months. So they showed that basal cortisol below 5, so we go to the Greek units now, was in around 9%. Peak cortisol of below 18 on the insulin tolerance test was in 15%. And they also described that one of these patients developed an Addisonian crisis during pneumonia. So there is indeed compromised response of the HPA axis in patients who are on chronic opioids. What is the reversibility of this phenomenon? The time course of this has not again been systematically studied, but in case reports, it seems that the altered function of the axis improves or returns to normal after discontinuation or reduction in the dose of the drug. And again, we need further studies which will lead to safe and cost-effective clinical guidelines. We need data on the real prevalence of hypoadrenalism for different opioids at various regimes and routes. We need to clarify what is the real clinical significance and what are the potential consequences and adverse outcomes of these biochemical findings, particularly when there is only modest reduction. What if this compromised response of the cortisol is an adaptive effect which has no clinical significance? We really don't know. And what is interesting is that it has been shown that in heroin addicts, there is a change in the diurnal rhythm of cortisol with lower levels in the morning. So a lot of is happening there, and we still don't know what is the pathophysiological significance of these changes. And again, we need data, robust data, which will guide us on the reversibility and the time course of hormonal changes after cessation or reduction of the opioid use. However, having said this, I think that we need to be on the safe side. Patients on opioids should be considered at risk of hypoadrenalism, and an early morning plasma cortisol or dynamic assessment, particularly in the presence of relevant clinical manifestations, is advised. How often we will do that, unfortunately, we don't know. And this is a review for those who may be interested to read a little bit more about the topic. We just published in the European Journal of Endocrinology. I'm quite proud to see 3 Greek names there. Thanasis Fountas, who is my pituitary fellow and has been with me for a year now. Shuteng Chai, who has just gone back to Malaysia to take a consultant post. Chrysula Kurkuti, who is in Greece now working. So for those who would like to spend some time of leisure reading about this effect, I would probably recommend this paper. And I cut a table from this paper as sort of take-home message. So for the hypothalamo-pituitary gonadal axis, what do we suggest? We know there is inhibitory effect. We need to check the blood testosterone, morning sample along with gonadotrophins. We need to, for females, we need to obviously check estradiol, gonadotrophins combined, of course, with medical history. Management, if we pick up a problem, discontinuation or reduction in the dose of the opioid, and if the above are not possible, consider gonadal hormone replacement. For the hypothalamo-pituitary adrenal axis, as I mentioned before, we are not sure of the clinical significance. Is it adaptive response to opioids? Is it true cortisol deficiency? On the other hand, there were cases of Addisonian crisis or cases with symptomatology resembling adrenal insufficiency, which showed improvement after the glucocorticoid administration. So the recommendation is to check a morning cortisol plus minus dynamic assessment if there are clinical indications, clinical manifestations, and we recommend that this has to be done in consultation with an endocrinologist. We wouldn't like other specialties to start doing short synactants because this will cause a lot of confusion and it will be a significant cost for the healthcare system. Management, again, discontinue or reduce the dose, and glucocorticoid replacement needs to be considered in cases with confirmed adrenal insufficiency, with reassessment if things change in the dose of opioid or regime generally of opioid. Somatotroph, I didn't touch it because, again, there is a lot of confusion here. After acute administration in human subjects, there is stimulatory effect. And it has been shown that there is inhibitory or no effect after administration of after administration of this for therapeutic purposes in heroin addicts, like giving methadone. We don't know what is the clinical significance. We don't know if there could be any benefits for the assessment of the somatotroph or of offering growth hormone replacement. So we are still in the dark for that. For prolactin, we can see stimulatory or no effect, so good to check prolactin. In such a case, we need to, if we find hyperprolactinemia, to look at the impact on the gonadal axis, look at the presence of galactorrhea or gynecomastia, and again, consider discontinuation, reduction in the dose, or alternative opioid if needed. And the thyroid axis, it seems that there is no effect or clinically significant effect after administration for therapeutic purposes or in opioid addicts. However, it has been shown that the TSH levels are lower in opium smokers compared with healthy volunteers. Again, we don't know what this means in clinical practice. So, in conclusion, the opioid use is becoming an epidemic, and all relevant specialists need to be alert for monitoring and for management of endocrine adverse effects. And this is where endocrinology plays a major role. And as I said at the beginning of my presentation, this is an area which shows that endocrinology is expanding and is certainly complementary in many, many other specialties. And no doubt that we need to find predictive factors, and we need to establish evidence-based protocols for opioid-induced endocrinopathies. And this is for the benefit of the patients, but also the benefit of the healthcare system. Thank you very much for your attention.